Good morning, everyone. We're just going to get started. Thank you so much for joining us today. We're very happy to have you all here, and we're looking forward to an interactive and exciting and interesting day with you. We just have a couple of housekeeping items that we'd just like to clear up. One is that this is an all-day seminar. So if that was not clear on the website, you're more than welcome to, of course, stay with us all day long. And we'd be happy to have you here with us. So that's one thing. The other thing is that there's a bit of a change in the schedule that did not reflect in the website. So our second speaker this morning at 10:30 is Marnie Thompson. And at 1 o'clock in the right after lunch will be Maxine Ratner. Although I think on the website it's the other way around. So just to let you know that. We have a cancellation, unfortunately, at the last minute yesterday. Shirley Otis Green will not be able to join us today. So we've just extended and left a little bit more time for discussion and for interactivity, which we thought would be really great to have an opportunity to talk to all of you and have some more discussion around some of the issues and the thoughts and reflections of our speakers. So we're looking forward to that as well. I think that's it for that piece. We are going to just do a brief land acknowledgement, and then we'll get started. We would like to begin by acknowledging that the McGill International Palliative Care Congress is taking place on unceded Indigenous lands. The Ga-Nyengahaga Nation is recognized as the custodians of the lands and waters on which we gather today. Tiohtià:ke, Montreal, is historically known as a gathering place for many First Nations. Today, it is home to a diverse population of Indigenous and other peoples. We respect the continued connections with the past, present, and future in our ongoing relationships with Indigenous and other peoples within the Montreal community.
Now for some more housekeeping issues, continue medical education credits. It's supposed to put that on the slides. By the way, my name is Patrick Rivage. Welcome, bienvenue à Montréal, welcome to Montreal for this International Congress. We're happy to be back and in hybrid mode, and hopefully that we could have those slides on. For the continuing education, medical education. No? No slides? Oh, there they are. Thank you very much. So the continuing medical education desk is located at the main lobby area. So you could go sign in for your daily accreditation. Certification of attendance will also be emailed after the Congress, of course. We would like to thank the scientific committee that overseen and had to deal with this organization nightmare in the COVID pandemic. So our kudos to that committee who did a great job to have this Congress happening in this delicate pandemic condition we're all dealing with. So heads up to Bernard Lapointe, Linda Christensen, who are both part of the McGill Council Palliative Council. Also to Vincent Desgenais-Boulay and also Susan O'Brien, who were key members of that committee. We would like also to acknowledge all the other members of the part of the list. It's like, I won't read the list, it's kind of a movie generic, nobody pays attention, but there's a lot of key people behind the scene that makes the things happen, and we're all grateful for their involvement. This program has received educational grants from all the following parties. You have them on the website, but we need to acknowledge them and thank them, because without their participation, this Congress wouldn't be possible to hold in this great venue of ours at the Palais de Congrès in Montreal. At the conclusion for our learning executives, we'll examine the core values of care and compassion at local, regional, global levels, and it kind of resonates very much with our presentation today. If you look at the title, it's looking at the psychosocial care lens at the individual, family, communities, and at a social level. a very social work-like title, but really looking at the aspect of death and dying within our own settings, but also abroad and with a social context. Define the challenge and solution in conducting palliative care research in an interprofessional environment. Describe the latest development in science, medicine, psychology, pharmacy, supportive care, social work, and spirituality. So having the holistic approach related to end-of-life care. To assess the latest development in science, medicine, et cetera, related to end-of-life care also. I really want to skip that quickly because you have the access, and we would like to give more time for speakers. They also have worked very hard, so we want to give them as much time possible. We like also to evaluate the consequence of COVID on grief and bereavement. There's been a lot of research in the last few months and year about how COVID has impacted the grief resource, but also access to those resources. So there's been a big movement to look at the impact of COVID on rituals, on death, on dying, and views of how we look at death in our society, how COVID has kind of influenced when we get on we used to get on a daily basis almost a death toll, how that influenced our psyche and how it influenced our relation to death and dying, and how we view our interactions even within our society members, who's vulnerable, who had vaccination, who didn't. So there's a lot of discussion we can have during the break time and how it impacts. And we're lucky enough to have people from around the world that could share their experience, and hopefully that will be something that we could have in our conversation. Being mindful, there's also, you have your different color coded badge. If you didn't get your sticker, if you're not comfortable with interaction, get your stickers at the booth and make sure that you have the right color so you can mingle with people at a reasonable distance if the people are not comfortable with those interactions. So without any further delay, I'll let Zelda present our guest speaker.
Hi, I didn't introduce myself. So I'm Zelda Freitas. I work here in Montreal as a clinical seniors advisor at one of our healthcare networks. And I work with Patrick. So we're very happy to be here. One of our planning committee members is not here today, and I'd just like to acknowledge all the hard work that she did with us in helping to put this day together. Susan Blacker, who is in Toronto and who was able to work with us to have this day. So I'd like to introduce our speaker today, this morning. We are very honored to have Terry Altilio with us this morning. Most of you will recognize that name because that name means so much to us in social work and psychosocial practice in palliative care. Terry Altilio, I hope I'm pronouncing your name properly, is a licensed certified social worker and a palliative social worker with over 30 years of direct practice. She is a recipient of the Mayday Pain and Society Fellowship Award in 2006 and a Social Work Leadership Award from the Open Society Institute's Project on Death in America, which supported a social work postgraduate fellowship and a social work listserv, which currently networks over 900 social workers. I encourage you to get onto that listserv. It's a wonderful, wonderful resource. Sorry, I had to add that in, Terry. In 2013, Terry was selected to receive the Project on Death in America Career Achievement Award from the Social Work, Hospice, and Palliative Care Network. She lectures nationally and internationally on topics such as pain management, ethics, palliative care, and psychosocial issues in the end-of-life care, teaches in social work programs at New York University, Smith and Fordham, and is a guest faculty in an internet course through California State University, San Marcos. In addition to co-authored journal publications, she is a co-editor with Shirley Otis Green and John Cagle of the second edition of the Oxford Textbook on Palliative Social Work, published in 2022, and co-editor with Bridget Sumser and Megan Lamina of Palliative Care, a Guide for Health Social Workers, published in 2019. We welcome to the podium with great honor, Terry Altilio.
Thank you all for being here and for sharing this time with us. I just will say really quickly that I'm having to fly back after this talk, so I'm going to be sort of moving very fast. However, what I want to do also is to give you my email address so that you can email me directly, and also if you want a copy of these slides, email me directly. And the email address for that is terryaltilio@gmail.com. It's very complicated. So I'm going to start this talk. I was really, the invitation for this talk forced me to think about things that I think about in isolated sort of silos, and to pull things together in a way that may have some meaning for you. It is not, once again, so many of the talks I've lately been doing, it's not, once again, a talk that's necessarily designed to elicit agreement. It is designed to elicit attention and intention. So think about it that way. You will see a perspective, and this perspective comes from the work of having edited those two books, really. And I'm going to talk about the two books, so maybe it's a conflict of interest. So Oxford Book royalties, for anybody that really thinks that you make a lot of money doing this, forget it. It is absolutely amazing. But the nice part about what comes is it comes in January and June, and you never know how much it's going to be. So that's really sort of fun. But you can never count on it for anything that's important, other than travel. Put it away for travel. So the learning objectives. At the conclusion of this presentation, I'm going to move these. Participants will be able to review the evolution of the specialty of palliative social work with attention to identity development within healthcare settings, reflect on the process and impacts of affirming and evolving palliative care skills within primary health social work and across professions, create a vision of specialist and primary practice as inequities and social determinants of health continue to evolve as a shared focus of interprofessional practice. I am a social worker, so you're going to get a view of psychosocial care from a social work lens because it's the only one I have. That's the one I have, and that's the one I use. How many social workers in the room? Yeah, okay. And psychologists? It's hard to see. Chaplains? Child life? Let's see, art therapists? I'm not getting, so the folks who didn't raise their hands, what's your specialty? What's your profession? Nurse? Oh, great. Yes, okay. Anybody else? Yes, okay. Physician, oh, great. So we have you're going to have a wonderful day. You have a wonderful blend of lenses, right? Of ways that folks are taught and the way that they perceive the same situation. That's what's so beautiful about a team in my brain. It's not always, people used to say, why do you need to be in all the family meetings? And I would say, because I listen differently than you. And why do I listen differently than you? Because I have a different training. I bring a different training. That's why you can't hear the way I hear. Okay, so that's a learning objective. And I have to say this, that the CanMed competency framework, the competencies being addressed are communicator, collaborator, leader, and health advocate. Why a kaleidoscope? Like a kaleidoscope, which is every now and then given a turn, society arranges successfully in different orders elements, which one would have supposed immutable, and composes a new pattern. So that's what we're going to do. That's what I'm trying to do for the next 40, however many minutes we're together, is to really change a little bit the framework and the lens through which we look at the work that we do. This is just a kaleidoscopic picture, which I think is quite beautiful. And this is, there are a lot of words here, but I wanted to put a lot of words in this slide because they set a context. McGill, I don't remember her first name. This is an article that's been written from 2003. You can get it free on the web, I do believe. It's in the bibliography at the end of the slides. And she wrote an article about excavating our frames. Frame-reflective conversations can be fraught with difficulty, partly because official discourse leaves so little room for them, partly because they are subversive of official hierarchies of knowledge, partly because they demand personal transparency and mutual trust, partly because they demand that we step outside our own habitual and comfortable ways of seeing. Reflecting on our frames in dialogue with others, which is what you're going to be doing, we are free to imagine different ways of knowing, free to explore alternative worlds, free to engage in more emancipatory practice. Ethical and accountable practice depends on us learning to see and articulate the full range of our ways of looking, to help others to see what we see. The beginning of real dialogue. Perhaps social workers will lead the way on these kinds of conversations. Why a social work perspective? Because social workers in many settings are the first line of mental health. And we really need to think about how we infuse palliative care principles, palliative care skills into those folks who touch patients and families, many seriously ill patients and families. My perception of palliative care is not end of life. We did palliative care with people with serious illness. Whether they were going to die or not was not the issue. We joined with them in a diagnosis of serious illness and walked the walk, whatever that walk was going to be. So this is not a talk about end of life. It's really a talk about that framework for palliative care. So they're the first line of mental health, often practicing in systems where social work is a minority. Nursing is not a minority. Physicians certainly not a minority. We're going to talk a little bit about counselors sort of are in the same range as social workers. I'm going to talk a little bit about what it means to be a minority in settings, in the kind of settings that we work in. They're considered to be core team members in many places and according to many definitions of palliative care, with role and concurrent responsibility for psychosocial care, and it's a profession with a social justice mandate, which is a whole other conversation because many of us have been looking at our social mandate and social justice mandate and truly do not believe that we have maintained that mandate, that we have been in fact absorbed by hierarchy and power structures that have made us collude perhaps with values in a way that would not make us comfortable if we took one step back. So this is just a slide that I love. It's the Sahara Desert. I like shadows. I think it's interesting to think about the shadows in our own life, what we carry with us, and it's a picture of what we're going to excavate a little bit, try to put a little bit more substance to these shadows. So let's start by excavating in Great Britain and in Canada. So, and there's a book floating around here by Balfour Mount. He just wrote a book that's about this thick. It's a little thinner than the Oxford Text of Palliative Social Work, but it's floating around the conference. So in 1973 and 1974, Balfour Mount who was a Canadian surgeon. A lot of you know much more about him, I think, than I did before I started to put this talk together. And he was replicating a model of care informed by the work of Dame Cicely Saunders, the founder of the Modern Hospice Unit, who trained as a physician, nurse, and social worker. So she was the embodiment of a palliative care team, all in one person. She moved care beyond a mind-body, thank you, Patrick, a mind-body dualism to a total pain construct, integrating the physical, social, psychological, and spiritual elements of personhood. So Balfour Mount wanted to do a pilot project at Royal Victoria Hospital. He called it palliative care. Why? A choice influenced by my Francophone colleagues who said that we could not use the term hospice because in France the word had a pejorative connotation that suggested a dumping ground of mediocrity of care, signifying the worst of nursing homes. So you see from the very beginning this challenge about what are we going to call ourselves and why are we going to call ourselves in a certain kind of way? What is the dynamic behind that decision? And palliative meant to improve the quality of, to cloak, to reduce in violence, to lessen or abate, to mitigate, to ease without curing, to palliate as in to palliate a disease. So it seemed very appropriate and a very appropriate choice. So what's in a name? This sketchy origin story foreshadows a dialogue about the scope of palliative care, its connection to hospice, and ongoing efforts to craft acceptable language for different settings, countries, patients, families, funders, referral sources, and beyond. This dialogue continues, which amazes me, having been in this work for so long, to keep discussing what we are going to call ourselves seems very significant to me. It's like, why can't we get over it and just call ourselves what we think we ought to call ourselves and march on? You know, do the work. I had a student who once said to me, lead with the work. Do the work. So it's very interesting because the dialogue continues in organizations and in institutions 30 years after, 30 years, it's more than 30 years, to 70s to 2000 is 30 years. So we're almost into 50 years, right? 50 years. Oh, that is a 5, Terry. Okay. After Dr. Mount's thoughtfulness about crafting language to make this specialty palatable to others, you find that conversation. What are we going to call ourselves? So oncology will give us referrals. What are we going to call ourselves? Rather than believing that people can be educated to understand what palliative care means. Patients and families can be educated. We just need to make a concerted effort as to what it means, that it doesn't necessarily mean hospice or end of life, that we can join with people along the continuum of illness. So this is as current as 2020. Diane Meyer had an article in the Washington Post and you know Diane Meyer is the leader of the Center for the Advancement of Palliative Care in the States. She has a very loud voice about palliative care. So what if she contributes to an article. It says, in pandemic era, the term palliative care is even more scary for some, so specialists want to rename it. That was Diane Meyer they were talking about, wanting to rename it. Rename it what? Rename it what? So it's just interesting to listen for that theme of what it is that we call ourselves, because it's symbolic and it's significant. We don't attach to a body part. We don't attach to certain treatments. Because we are a holistic kind of approach to taking care of human beings, it's not like we can be nephrologists who take care of kidneys or oncologists who take care of cancer. So we ask people to identify, if you will, with the humanity of the person that we're taking care of and join at that level. And we also, most of the time, when we're really good at what we do, we know how to do pain and symptom management. It is amazing to really work with people who know how to do pain and symptom management. So that dialogue was in the States. What is it about the origin story, evolution, and scope of palliative care that keeps us defining what we do, who we are, and what we call ourselves, as concurrently the evidence grows to support the specialty that continues to integrate varying degrees across countries, settings, and diagnoses? So as palliative care builds a research base, because everybody wants data and outcomes, everybody builds a research base, we're still having this conversation about what we're going to call ourselves. So if we change the name of what we call ourselves, what does all that research mean? Where do you put it in terms of the evolution of the specialty? So it's an interesting conversation that a lot of other people don't have. They do not have it. Excavating the past in America, I thought it was interesting that this project was called the Project on Death in America. And really it was the United States. That's what this project covered. From 1994 to 2003, George Soros, who's got lots of money, still has lots of money, gave $45 million grant-making project to transform, what a wonderful imagined goal, transform the culture of death in America. If you think about those of you who are in the U.S. right now and think about the wars that are going on around race, around culture, around gender identity, but this project was going to transform the culture of death in America, a lofty goal. And you can only, I guess, have that kind of goal when you're a billionaire, like George Soros is and was and is. So it supported 87 faculty scholars, 82% of whom were MDs. They were physicians, and 18% nurses. And where were we in all this? Where was the psychosocial element of care? At some point in time, they decided to address the physician dominance in the program. So what happened? Nursing leadership instituted an end-of-life care, so that was great. Some board members also agreed, in the face of resistance, for the greater prominence to be given to social work perspectives in end-of-life care. So there was resistance on the board to inviting us to participate, inviting the people who carry the psychosocial mandate through many institutions to join this project. But the resistance was overcome, and in 2000, the Social Work Leadership Program was launched under the leadership of Grace Christ. Susan Blacker had an enormous presence in that project, and it was to foster research on new social service delivery models, which is really interesting. Living this long and getting this old, I've started to read some work that talks about how challenging it is to think that some of the work that we do can be captured by data, can be captured by whatever those kind of controlled trials they talk about, which are supposed to be the sort of the top level of research. And I think part of this identity thing with psychosocial people is to begin to talk about the fact that our work doesn't necessarily get captured according to the way you study blood counts and diseases and so on and so forth, that this is about humanity and about human beings. And what we are learning, the dialogue that we're having now, which is so beautiful and so wonderful, is about truly understanding the difference in cultures. Not being culturally competent and think that that's the beginning and the end of what we understand about each other, but actually engaging in a process of discovery and understanding how important cultural identity is, and adapting our systems rather than asking folks who come into our systems to adapt to our systems. It's a very interesting time. It's very exciting, I think. It's a very exciting time, even though it has evolved from a lot of pain and suffering. A lot of pain and suffering. So we had 42 social workers, 50% were academics with PhDs, 50% were master's qualifications. That was me, and we worked in direct practice. This is, do you know David Clark? Yeah, David Clark's a really interesting person. He's in Glasgow, Scotland, I believe, does a lot of thinking and talking about end-of-life care and palliative care and hospice. He's really quite lovely to read because he's very accessible. And he wrote the book about the Project on Death in America. And one of the things he wrote about is this. So this is a map of the United States, and I don't know where the pointer is, and I don't care. So over here is California. So that's California, and over on the other side is New York. So in the beginning, when we did the Project on Death in America, they would bring all this group of people, the doctors, the social workers, anybody who participated, out to Lake Tahoe in California for like a retreat, where you would hang around with each other for 3 or 4 days and, cross-talk and do whatever important stuff you needed to be doing to influence the culture of death in America. By the end of the project, I'm going to say maybe the last 2 years, it could have been the last 3 years, everybody else was still in California, and the social workers were meeting on the other side of the country in Long Island. Now, you could say that was because there were too many of us, but, by the time we were up to 42, we couldn't figure out how to find space in Lake Tahoe. You social workers, psychosocial people, we can share rooms. There's ways to mediate, right? Well, you can share a room. Who cares? I would have been in a tent. I don't care. It's Lake Tahoe. It's beautiful in Lake Tahoe. I didn't care. But that was not the solution. The solution was we were in New York and everybody else was in California. So that's just a very interesting symbolic. When David Clark interviewed me for his book on the Project on Death in America, I said to him, this was totally significant. It made me weep, actually, how sad it was, Still does. So that was in 2000. Now we come to the current. This is a 2021-2022 version of that map, and it argues for continued efforts at collaboration. So the Journal of Palliative Medicine did a series of articles on psychological elements of palliative care. They're beautiful. They're really important. Yes, I'm so glad they did it. There is not one social work author on any of those. In any of that series, there's one place where they say thank you to some social worker for having made some kind of contribution. So that really sort of blew our minds. Vicki Leff and I wrote a piece, a letter to the editor for the Journal of Palliative Medicine, and said, really? In 2022, you couldn't find a social worker to work with you on this project? We didn't say it that way. We wanted it to get published, and we didn't really, we wanted to call attention. Like, how does this happen in 2022? And yet it still happens. So part of it is, a lot of it is really on us to figure out how we are going to assert this aspect of care as important as other aspects of care. I'm going to switch now, I think. Let me just see. Yes. Okay, so what did we do in Long Island? We had fun. What did we do in Long Island? We ended up, what was launched from this work that 42 social workers did together. We had 2 summits with national and international participants, a couple of years between them. The National Association of Social Workers created standards for palliative end-of-life care. There were master's level courses, post-grad certificate programs. There are fellowships now, postgraduate fellowships in palliative social work around the country. Not a ton of them, but a significant number. It's been raised over the years, the numbers. There's a Journal of Social Work and Palliative and End-of-Life Care, and there's an organization called SWIPN, Social Work, Hospice, and Palliative Network, and the listserv that Patrick talked about that we launched years ago now has over 900 social workers on it. So a lot of stuff came out of that. And 2 decades later, where are we? It is 2 decades. You got that one right. There's a commitment in many places that social work is part of the core team, part of the core palliative care team. There is now a certification, which has been one of the most exciting things for me, because what NASW did was important, but it had no test. It had no demand that we as psychosocial experts and psychosocial clinicians demonstrate some kind of competence. So now there's an exam, and you get this APSW-C. It's called the Advanced Palliative Hospice Social Worker Certification. We've got 2 textbooks. We did the first Oxford textbook in 2011. We did the second one in 2022, just out. 150 authors around the country and around the world, and 103 chapters, which blew my mind, and I worked on putting it together. But it was very interesting, because you look at it now, and there's a whole section on interventions, so that instead of saying in our notes we provided support, everybody in the palliative care team provides support. The volunteers provide support. Sometimes the people who come in and are cleaning the floors are providing support to patients. It is only COVID that has allowed us to see those folks as part of the team. Right? All of a sudden, they became essential workers. So providing support is not, for me, a note that documents the expertise of a professional. We need to be able to talk about anticipatory guidance, whatever it is that we do. Help patient to partialize their experience, problem solving, whatever it is that you do with a patient. In terms of engaging with them, because why do we have the right even to engage if we are not making some kind of a difference? And sometimes that difference is simply your presence, the presence of a person who listens. So we now have these different kinds of creations, social work competencies in palliative education in Canada. So you did work up here to create competencies for social workers in Canada. The European Association of Palliative Care Social Work has a task force, and they have competencies. So it's really interesting to think that there are competencies that reflect different parts of the world. And that feels to me like it's appropriate, because practicing certainly in various parts of, for example, Switzerland, would be different than my practice in the United States. Switzerland, where there are some parts where euthanasia is acceptable. So there are policies and circumstances in the environment that inform competencies. And then there's the World Hospice and Palliative Care Social Work Network, which I think is a relatively recent creation in an effort to pull people together, pull social workers together around the world. So I'll take a drink of water. So we created a specialty. Very exciting. I mean, a lot of us were on the ground working on creating a specialty. We call palliative social work a specialty. That's why we have this big fat book, right? We call ourselves a specialty. And we continue to advocate for staffing that supports working to the top of our license. What does it mean to work to the top of your license? And no matter what your skill, no matter what your profession is. Nurses, this is a phrase from nursing actually, working to the top of the license. As opposed to, and I think that, I think what we have lost in some ways is when we are given tasks, for example, like arranging home care, or when I first started social work in hospitals, I was ordering hospital beds. But what I didn't realize is that why I should, ordering a hospital bed now is like pushing a button. It's like nothing because we have so much technology. It's really, really easy. Why do they need psychosocial people to be involved in that? Because we're the people that ought to be understanding and try to understand what it means not to sleep in your own bed anymore. What does it mean not to sleep with your partner anymore? It's not about the physical thing. The physical thing has meaning. It has attributed meaning. We need to discover the attributed meaning for people. That's why we need to be there. That's why we need to be there. When we transition, transitions are really such important aspects of the work that we do. And I don't think that we pay attention so much to the grief that's involved when somebody's leaving the hospital and going to some kind of facility. And the fact of the matter is they may never get home again. They may never see their stuff. Never. That's the work for us. That's the work. Okay, that's the top of the license. And it also created demand. And we know, and everybody's talking about this, physicians are talking about this, nursing, all professionals who are doing palliative care are talking about this, that the specialist level teams are not going to be able to meet the needs of all the patients who are diagnosed with serious illness, have symptom management, and so on and so forth. So there's this whole conversation started about primary skills for all healthcare clinicians. Primary skills for physicians, primary pain and symptom management skills for physicians. You ought not to need a specialty team to manage pain and shortness of breath. It needs to be a primary skill because specialist teams will never meet that need. It's impossible. In addition to the fact that people are suffering while you wait to make the referral and all that other kind of stuff that gets a specialist team in. So it can't be met by a specialist, nor should it be. Hence, for some, it links to a focus on workforce issues and primary palliative care across professions. For others, it's a focus beyond workforce issues. And this is something we learned from Colleen McKeown, who wrote a chapter in the guide for healthcare social workers. She says, it is essential to challenge the concept that the only purpose of a trained primary team is to address the gap in the specialty workforce. The call to attention that originates from a deficit model, because there are not enough of us, that's a deficit model, in the specialty workforce misses the opportunity to honor the quality narrative that palliative care is at its essence good health care. Good health care. So it ought to be accessible to everybody. And how do you make it accessible to everybody? And when we did the guide, what we began to think about, the three editors, was the following, I think. Yeah, look at that. There is a lot, my mind does have some kind of a stream of logic to it. For many discussions of primary palliative care skills prompted reflection. And that's what the guide did for us, the people who were editing, and edited the guide. And what we began to think about is, what did we gain when we created this specialty? And what might have been overlooked as we did the work of creating a specialty and integrating as part of the team? And what we think, what we sort of surmise in the Oxford text. Phil Higgins is a really interesting person. If you ever get to read anything by him, he just writes beautifully. But in the first book and in this second book, he wrote a chapter which is called Guess Who's Coming to Dinner? And the chapter is about social workers' presence in healthcare settings where we are a minority. And it talks about the identification as a minority and how that evolves. And did we in some ways, and do we in some ways, identify with the majority to be accepted? We use their language and so on and so forth. And I can feel that in me. I know that process when I was in an unfamiliar environment and a minority on my treatment team. I know that process, and I know how long and how difficult the suffering that got involved with not only facing that and understanding that, but then having to do something about it, not feeling so damn sorry for myself. You know, it's like, get over it. You know, you have a skill set. You need to assert yourself. That's on you, not on them. That is on you. That's on you. So as a minority in hierarchical healthcare settings, did we align with power and prestige? Acquiesce and assist in the evolution of a specialty grounded in white Western values, which surely in the States it is. It is grounded in white Western values. Where people are looking at this very, very actively now in the States, and I suspect that's happening in different parts of the world, and certainly in Canada, to look at the values of what are the values implicit in advanced directives. How do those values cohere with the Muslim husband who said to me, your prognostication subverts the will of Allah. Only Allah knows when people are going to die. We don't talk about death until it happens. Then don't worry about it. We'll take care of it. We'll take care of it, as opposed to my hospice colleagues who were like, what's the funeral arrangement, right? How are they going to handle this body after the death? All that proactive kind of anticipatory thinking that we think is important, and we impose it on other folks. So it's really a wonderful time to be thinking about that, and the psychosocial people need to be leading that. We need to be leading it. So, some personal reflections. Had we developed a specialty that might have inadvertently created a hierarchy within health social work community, rather than building on the fluidity of skills, rather than thinking about our social work colleagues who work on the oncology floor, who work in the ICU, who work in all different home care, wherever it is that they work, how do we join with them support their skills, affirm their skills, build when we need to build, and come in as specialists when we need to come in as specialists. How do we know that, and how do we change from this sort of, oh, I'm a specialist, I'm a palliative care specialist, to this idea of affirming the skills of others and building on them? Same thing has to be done in all professions. Same thing has to happen in medicine. Same thing has to happen in nursing. In chaplaincy, same thing has to happen. Because we will never have, and as Colleen says, it's not an issue of numbers. How many of us are there? It is an issue of looking at healthcare for everybody and thinking about how to enrich it and to treat people as human beings with the humanity, shared humanity. So did we align with ideas? Some people call it the philosophy of hospice, the philosophy of palliative care. I don't quite, never have understood that, so I don't use it actually, as if they were facts, rather than seeking to understand how ideas are received, values and beliefs are held from varied worldviews. One of the most richest parts of the work for me has been to engage with people who think about the world much differently than I ever think about it, and some of it is so unbelievably brilliant and creative. I will never forget this man from, it was either Nepal or Bhutan, who died on our floor. And before we could move the body, that the family would not accept that he was dead until somebody from the spiritual care community came in and did some kind of a thing with the skin and touched his body and so on and so forth, to say, yes, he is dead. Yes, he's dead. The richness in this work is really absolutely wonderful. It's a gift for some of us, So, and did we remain silent? Because I know I certainly did, for a long time, when there were opportunities to enhance the work of colleagues. And did we remain silent when we were sometimes witnessing harm, and we knew harm was happening? But this idea, how you balance acceptance, acquiescence, identification with power and hierarchy, and then decide how you're going to not necessarily separate from that, but join in a way that helps people not to do harm. Why would we remain silent when we can identify somebody doing something that we know is harmful? It's a really interesting dynamic. Why would we remain silent? And we remain silent because we're balancing, right? We're balancing what is the negative side of speaking up right now. And not only that, how do I speak up right now? What is the language that I use? And sometimes we miss the opportunities. But then we go back, you know. It's a learning, and it's really something also I would like to say that our team should count on from us. If you do not work in a team that has enough safety, psychological safety, it's a really wonderful concept, psychological safety. We need to build teams where it is okay to confront each other. And I don't mean to be angry and abusive and all that kind of stuff. I mean to say, I need to talk with you. And for people to say that to us. I don't understand how we had all these conversations about resuscitation status. This is such a big deal in the States, about resuscitation status, and the patient told us very clearly he wanted an attempt at resuscitation, and when the time came, you called the family to try to change the decision. What is that? How do we allow that to happen without sitting down and saying, I don't understand this ethically, morally, and so on and so forth. I don't understand it. Help me to understand. I need your help. There are many ways to engage in these kinds of conversations. I need your help to understand. Okay, so these are a sampling of wonderings. Do we value varied ways of knowing? Do we honor the work implicit in joining with narrative speakers as they bring their subjective experience into data-driven systems which expect accommodation? I like this subjective-objective sort of difference. So our patients and families bring their subjective experiences into environments that often value objective knowledge, data. So how do we bridge that? How do we help folks? How do we help narrative speakers? One of the reasons why women are undertreated for pain, people believe, and the data and the articles and what we've learned about why women are undertreated for pain can be quite profound. And startling, actually. But one of the reasons people believe is because oftentimes we're narrative speakers. We speak in stories. And the people don't have time for that. Don't have time for that. So that's another avenue of advocacy. We can't expect people to do this work in 15 minutes. We can't expect a doctor to do the kind of palliative care engagement and thinking about goals and values and so on and so forth and give them 7 minutes of time or 15 minutes of time. So that's the kind of advocacy, social policy advocate, that psychosocial care demands of us. It demands of us. How has our search for data to support our work dwarfed the awareness that our work and human experience cannot always be presented by data and singular ways of knowing? Because there are many ways that people know things. Have we joined in a shared language, such as poor historian, non-adherent, doesn't get it, joining in judgment rather than molding systems that seek to understand, engage, and become trustworthy? Many of our systems that we work in are not trustworthy. They have created and done things in the community and with people in the community that have made them untrustworthy. So that's on us. How do we begin to build trust with communities that are underserved and living in toxic environments and sick? So over the past 2 years through COVID, right, we had a pandemic. And what did we see? Glaring inequities. In addition to the pandemic, we saw in the United States, as clear as you could see, the killing of a black man by a police officer, as clear as you could see it. So in the United States, it wasn't just a pandemic that bubbled up all kinds of outrage, if you will, about racism, colonialism, all the kinds of things that we're paying more attention to than we have in the most recent, in a very alive way, let me put it that way. The pandemic and glaring inequities exposed harms of colonization and witnessed violence driven by hate and racism. They demand reflection and action related to the social determinants of health and the systems that have proved untrustworthy, fostered inequities, and done harm. It's a large expectation, but it is a shared one. I'm going to talk in a minute about structural competence and some of that work. And then in the States, there's this advent of something called open notes. And people can, go on the web and access their notes and see everything that we're writing about them, unless we want to protect certain information that needs to be protected. But you can't always do that. You can't protect everything because you don't want patients and families to read your notes. You've got to figure out how to write notes in a way that are not judgmental, that do not reflect racism and bias, and so on and so forth. And so we're myself and a colleague, Ann Kellerman, are doing a lot of conversations and a lot of talks on word choice and language in palliative care. And in fact, that's why I have to fly out of here quickly. So the advent of open notes in the States have really motivated a lot of people to be thinking about what they're writing, how they're talking about people. How do we move psychosocial to a true focus? Because social workers also talk about person and environment. Moving from a singular focus on the individual to acknowledge the impact of systems that impact health. So instead of saying this person is non-adherent, we say that this patient was unable to get their medicines because their pharmacy in their neighborhood doesn't cover it. They don't have insurance policies, they don't have insurance coverage for it, so on and so forth. So you take the blame off the individual and expand to the systems that we live in. And then figure out how to change those systems. And if you're discharging somebody, if you work in a hospital and you participate in discharge planning, and you haven't figured out how that family is going to get their medicines when they go home, like in New York, we knew if they went to certain neighborhoods, they weren't going to be able to get certain opioids. So you bring them in a pain crisis, you manage the pain, then you get them ready to send home, and you don't think about whether they can get their medicines or not. Who's going to do that thinking? We can't ask patients and families to know what we know about the world and the world's ability to support their care. So we have to do that, because you don't want somebody in the States, you don't want somebody bouncing back into the ED in 30 days. That dings you in the United States. I don't know what happens, but they keep track of that stuff. So you think about institutional goals. And you say to people, hey, listen, we don't want, in addition to the fact that we don't want a recurrence of this pain flare, that minimizes all the work that you just did, creates another crisis for this family, builds more mistrust about our inability to take care of them. So how are we going to make sure they get what they need? And everybody needs to be thinking about that. And our social work, social justice commitment in many places is being interrogated and challenged. I mean, I can tell you, I was one of those people who worked in residential treatment, and we plucked children out of the Bronx, out of Harlem. We brought them to Dobbs Ferry, this beautiful place with trees and so on and so forth, totally white school, and they were afraid of the silence. The silence was so uncomfortable for them because, and where they lived, there was this noise, the level of noise, in the city was so different. But we plucked these kids out rather than figuring out how to build systems where they lived that might have protected them and their families from being ripped apart. So we did that. So where in all this are we in 2022, and how does it relate to palliative care and to psychosocial care? So as we think about crafting a future, silence is not an option, no matter where you're working. And we have a responsibility. As psychosocial people, we're often participant observers. We're participating, but we're also observing what's going on, right? We're in a family meeting, and you're observing the process. That's a participant observer role. So we need to learn and lead, restore and repair. I should talk just a little bit, I think, in this next slide about restoring and repairing and using the space and place that you have. They talk about capital. What kind of social capital do you have? What kind of power do you have? It took me years to figure out that as the only staff member who stayed stable in a teaching hospital on our team while attendings and fellows changed, I had power. Not only had power, but I had responsibility. And my responsibility was to make sure, I remember this fellow who came in and looked at our list of patients and diagnoses and so on and so forth. He was like, I think we should do the list differently. We should do it this way and that way. I was like, no. Just because you're here now, you're not changing the way we organize the list. You just don't have that power. So when you have to think about, as a psychosocial person, what power do you have? And how do you use that? They call it capital, social capital. Physicians have a lot of capital. I don't know what they call it in the physicians' world, but it's capital. I learned that term very recently. What is the capital that you spend to make change and to make things better? And how do you judiciously use it? And so we need to be thinking about beyond the nuclear team. I consider the teams that I worked on, they were always teaching teams, and there was a core group and a lot of people who changed from 1 week and 1 month to the next. And part of what we do as palliative care consult services is to move from the nuclear family of team to the extended family of colleagues across settings and specialties. So when we work with oncology, when we work with the ICU folks, I look at that as extended family. How do you enter those families? And that's part of psychosocial work. And we begin to value much more reciprocal learning. You'll see at the end of, if you send for the slides, you'll see at the end some wonderful articles. It's really very nice to do shared learning, depending on the setting that you're working in, because then everybody is learning together. And you hear another person's lens, the lens through which they look at things. And we absolutely look at things differently. I know if I were a patient who walks into the ED, I got to tell you, I want to see a doctor and a nurse. I do not want to see a social worker. I want to see a doctor and a nurse because I want you to fix me. I want you to do something that's going to make a difference to the situation that I brought in here. So let me start with a doctor or a nurse. On a systems level, we need to own the social determinants of health as a shared focus, engage institutional mandates to benefit patients and families. That's the mandate about people not bouncing back into the ED in 30 days. So how do we look at those mandates, instead of seeing them as the enemy, try to engage them in creating better care? How do we eschew silence when the mandates do not contribute to a shared mission of humane care for patients, families, and staff? How do we get beyond silence and actually express that out loud when we see it? Won't necessarily change. Things don't change quickly. They don't change tomorrow. But to not observe it, to remain silent when you see harmful things going on and you see policies that are not helping the staff, not helping the families, even though they may be well-intended. We need to speak up about that and interrogate the history of your institutions and professions related to bias and inequity and work to mitigate those. So this is on a systems level. Consider the idea of structural confidence. There's a person whose name is Hansen, Helena Hansen, I believe is her first name. She's a psychiatrist. She's an MD psychiatrist, works a lot with substance use disorder. She also has a policy, public health, I think, degree. Really interesting. And she's talking about, she has a video talking about, video and books, structural competence, which is this idea that you shift the focus from the level of the individual to the institutions, communities, policies leading to health competency, reframing the responsibility for resilience. You know, it's really interesting when you think about resilience and us talking about self-care and resilience and these wonderful, wonderful topics when people are working in systems that are oppressive, abusive. Like, really, you think this is on me? We need to look at the whole picture rather than, it's sort of an interesting comparison, isn't it? Because we do that sometimes with patients and families, and you heard it also through COVID in institutions, you know. Make sure you're taking care of yourself. All this kind, like when people were working and experiencing death and sickness in a way that nobody had ever experienced before. Nobody had ever experienced before. And expand the scope of clinical intervention and responsibility. Recognize that practitioners can bring symbolic, social, and cultural capital to bear in partnerships. And encourage documentation, this is part of Hansen's work, that moves from messages of blame of an individual and cultural presentations that acknowledge the structural systems that create or exacerbate inequity and vulnerability. Challenge universal concepts. I went to a meeting on physician aid in dying, and I went because I'm so conflicted about the topic. And I thought if I immersed myself in 2 days, I would come out less conflicted, which I did not, but I learned a lot. I'm probably going to go to another meeting and see if I change or see if I feel more comfortable. And so a person named Terry Laws talked about autonomy. She's an African-American professor, and she said, you folks talk about autonomy, you want signatures on papers. This is in the U.S. You know, we're nuts about advanced care planning in the U.S. You want signatures on papers. She said many of our families we don't think about individual autonomy. It is relational autonomy. It is a person in a family. When we make decisions, we make it together. Sometimes we bring in the community clergy. It could be many, many people that come together because that's the person's network, that's the person's support. That's who they count on, not us. That's who they count on. So she introduced me to this word, to this phrase, relational autonomy, and I had seen it. You see it all the time. I didn't know how to call it. I didn't know how to describe it. It's relational autonomy. Non-adherence for anybody who's doing psychosocial care, when you hear that word, it's a very dangerous, non-adherence and non-compliant is a very dangerous label to put on people. People will die because they've been labeled like that. Treatments won't be suggested for them because they believe they won't be able to follow up with the treatments and so on. A whole scheme flows from that label. Non-adherence is an invitation for discovery, not abandonment. It's an invitation for discovery. Mistrust. This was Terry Laws. She said mistrust can be situational. Mistrust can be protective. It's not that I, as a person, at my core, as a mistrustful person. I am mistrustful in your setting because you have harmed me. Your setting has harmed me. It's situational mistrust. And it can be very protective. I listened to a podcast the AMA is doing. AMA is doing a lot of work. AMA did on Native Americans, and they talked about dignified mistrust. That many of the way we look at it is it's dignified mistrust, and I can see that. And you probably can too. Oh, look at that. What does that mean? Am I finished? No. Yeah, I know. I have 30 minutes to go. Oh. I do not skip and chew gum at the same time. You know, when you're doing the internet stuff, and people start putting stuff in the chat, so it makes me goofy because I lose my train of thought. So I always tell people I don't skip and chew gum at the same time, but I didn't realize I was going to have to say it here. Okay, so yes, anyway, mistrust is very interesting. Advanced care planning, as I said, social workers are getting very involved in the states and have been on advanced care planning. Can't do advanced care planning without good medical information. How do you do advanced care planning without being able to help a person understand where they are in their medical illness? We don't have that language. We need to make sure we're doing advanced care planning in collaboration. It implies a future orientation. Everybody doesn't live with a future orientation. Doesn't live with a future orientation. Yet we need to help people to understand if they can't help us to direct their care and think about the future, there are certain things that will happen as a consequence of that, depending on where you live in the world, depending on the state that you live in the United States. If there's no advanced directives, no guidance about how to care for people, there is a process that will flow. And people need to know that because they don't understand that. How would they understand that? That's our knowledge. That's our knowledge. So they need to know that. That's anticipatory guidance, actually. Prognostication, I told you about the Muslim husband who told me that we were challenging the will of Allah, that our doctors thought they knew when somebody was going to die, and so on and so forth. Or even that somebody was dying, and that was a challenge to the will of Allah. So prognostication has different meaning to different people, and date is only one element in many people's worlds. End of life, you know, when I started to learn to do this work, I was always taught don't use euphemisms for death. You have to say death and dying. You have to say dying, so on and so forth. And then there were times when I knew it was inappropriate, and so I didn't say anything. I just, but I I missed the opportunities to say death and dying because it didn't feel right. But then I learned also from people and from patients and families that there are different ways that people think about the end of this life, the life of this body, the life of this body. Terry Laws talked about that too. That some people consider them transitions, crossing over to another way of being. Traveling. I sat with an African-American sister. I think she was a sister of the patient. And she said she's traveling. And I didn't need to say she's dying. Why did I need to say that? We all knew I knew what she was talking about. She knew what she was talking about. It was beautiful. It was really a beautiful moment, and over time, you can see how people will teach you how they perceive this part of life. This part of life. It's quite beautiful, actually. And so, as we document our work, there's a wonderful quote. It says, "It's care imitates language." That is, we tend to relate to people the same way we write and talk about them. And right now, CAPC, if you go, anybody who's a member of CAPC can go on their website, and they now have a talk on language that Ann and I did that they actually posted for their members, because there's a lot of research coming out now, consequent to open notes and consequent to the focus in the States on racism, colonialism, how that's expressed in healthcare, inequities, and all that attention being paid. There's a lot of attention, a lot of research going on related to documentation. And how does documentation affect, for example, there's a wonderful Goddhu, Goddhu, did a study related to persons who live with sickle cell disease. And the charting related to persons who live with sickle cell disease. And depending on the charting impacted the kind of pain management they got. Impacted decision making. So how you write things impacts decision making. And for some patients, how we talk about them and how we write about them will mean that they die sooner than they would need to do if we used other words, if we explain things in a different way. So there's a lot of research linking documentation and research to reinforcing or mitigating inequities and impacting outcomes, and that's very exciting. And as we look at psychosocial, this is just a sampling of things to explore, to think about how we do them, how we engage in them, and what the opportunity and potential is. To explore meaning and the opportunity and the practical aspects of our work. So I had a supervisor once, his name is Matt Lascalzo, really interesting. He's at the City of Hope now. He's been around for years and years, and he's brilliant, really. He said when he first started the work in palliative care, somebody asked him to write something in a chapter about insurance. Right? They were focusing on the practical aspects of the work that he was doing. And he said, sure, I'll do that. And he wrote this segment on insurance, and what did he do? He linked it to people's, to the meaning, for example, of having to apply in the States for Medicaid. What does that mean for somebody's dignity, for somebody who has always wanted to be independent and able to take care of themselves? So he linked it to the psychosocial aspect, just the way I was talking about, you send somebody home with a bed. What does that mean to them? In terms of the self, the life that they live, their relationship with their partner, and so on and so forth. What is the meaning of it? So he said, yeah, surely I'll do that. And then he took it in a direction of what do these behaviors mean? What does it mean? It's a practical thing, but what does it mean in terms of psychosocial and identity? So transitions, what is lost and what is gained and often uncertain. Will a patient ever see their home or their stuff again? My friend Jean Aylhart and I, she's a wonderful nurse, and we traveled, did a lot of work together. And I remember we walked into this patient's room. He was, I don't know, maybe in his 70s or 80s or something, and was like, you know, how can we be useful to you? And he said, can you find my stuff? And he used the word stuff. Can you find my stuff? Because he had moved from one floor to the next. Can you find my stuff? And we looked in the closet, and we were so glad his stuff was there. Because, you know, might not have been, but it was. His stuff was there. And it was, you know, little stuff. It's like not, you know, it's just his stuff. What were his possessions, my stuff? Can transitions that are well done represent a quiet opportunity to counter the inhumane legacies of separations? So how do we do this? How do we help families with changes and with separations and with going to facilities or whatever it is in a way that is respectful of the meaning of those, rather than what we have done in our various countries in the past, ripped people away from their families without any sensitivity, without any caring really, because we didn't consider them human. So can transitions represent a quiet opportunity? Equipment and home care, I've talked about a unique meaning to families. It's an invasion by the medical world. We often think, I can remember realizing that we get all excited. We're going to give people home care. You'll have a home health aide. This is in the States, right? But the other part of that is for some people, you're invading their home. You're bringing the medical world into what they have created in their lives. That's the psychosocial part of this work. That's the psychosocial part. It ought to be core. It ought to be core to this work. Has unique meaning in families. I remember a little Italian woman. I worked at Beth Israel downtown. It was a wonderful hospital to work with. It was close to Chinatown. It was close to Little Italy. We had patients, Ukrainian patients, Russian patients, all different cultures coming in. And this Italian woman we were sending home, we were all excited. She had a 2-story house. It was like they were going to put a hospital bed. I call them semi-electric bed. It feels better to me than hospital bed. Semi-electric bed on her first floor in the living room. She was like, that's not happening. I have spent my entire life creating this space. This is my home. If I have to crawl up the stairs to get to my bed, I'll crawl up the stairs to get to my bed. But you are not putting a piece of equipment in my living room. And I will forever remember her. Some of what we do has profound meaning to people, profound meaning. And I talked about this, that one might never share a bed again with their partner. Or sometimes we put home care in, and we've had people say to us that it was a message that the care that they were providing was inadequate, that somehow they had missed something. So that's a level on which we have to listen. We have to listen on many, many different levels. And lastly, a sampling of our work that links the past, present, and future. Valuing process no matter the outcome. I have made it up, and I'm sure there's some research somewhere that either says it has some validity or not. But I really think that if our physician colleagues could value the process as much as the outcomes that they achieve, that there would be less burnout in physicians, because they would see, like I came to see, that you may have a very, very important, meaningful spiritual process and come away with a decision with a patient saying in our country, I want you to try and resuscitate me. And we do that resuscitation, it's either successful, it's not, and it goes, and people feel like they have failed because they did not come away with an order not to resuscitate. So if we could help each other to value the process, that this was a beautiful engagement process with a patient and a family, even though the outcome might not be exactly what you asked for and what you hoped for and what you think is best. You know, we have ideas about what we think is best for other people. So I think it's interesting, it's important to think about process. And this is close to the end of this conversation. Well, it's a one-way conversation, Terry. this talk. And I know that parallel process doesn't exactly mean this, but it is the way that I think about it in my brain. I think about it as a parallel process. And I came to believe and to understand that, for example, symptom management, our palliative care colleagues who are experts in symptom management, those of us who engage in pain and symptom management from a psychosocial perspective, a multidimensional perspective, and help people with their thoughts, their internal dialogue about their pain, their catastrophizing about their pain, problem solving around their pain. What we are doing is not only intervening for some positive outcome in the present, but we have the potential to mitigate legacies of suffering in the future with this family, not necessarily the patient if the patient's dying, with the family, because we can impact bereavement and we can impact the narrative around the illness. Patients will tell us that. Family members will tell us that. They'll come into the hospital and they'll say, I know my father's dying. I don't want him dying short of breath the way Aunt Sadie died. So what are they telling us? That death entered the legacy of this family post-death because of unmanaged symptoms. Because of unmanaged symptoms. We can change that. That's another way that I think we can help each other to understand the value of our work. That it's not only the present, but that it actually links to legacy. It links to future. And you will have experiences like that. You know, all of a sudden you'll get a note that somebody writes to you. Said, I was thinking of you. You really helped me 5 years ago. You know, those are like, they floor you when you get those kinds of things from out of the blue. But what it makes you know is that you influence people in ways you may never know. You influence legacy. Searching for friends and family is another talk we do. Myself and colleagues do in the States. We have had some of the most profound experiences with patients who come in unrepresented. And because they may be unrepresented and cognitively unable to communicate and unable to share how they want their care to proceed. And in the States, depending on the state that you live in, you can hear that, you can see that with what's going on around pro-choice and abortion in the States. Each state feels like an autonomous being, maybe the same way in Canada, but I don't know, because I have enough trouble understanding what's going on in the States, being appalled by what's going on in the States. What we know is that depending on the state that you're in, before you can make certain decisions around the care of an unrepresented patient, you have to search for family. You can't just take that power and say, you know, like a person who doesn't have a roof over their head, who wants to go back to a life like that anyway? We won't resuscitate this patient, or we won't do this, or we won't offer this treatment, and so on and so forth. You can't just do that. You've got to search for family. You've got to search for somebody who knows this person and has some kind of a history. And even if the law doesn't tell you that, ethically we ought to be doing that. Morally we ought to be doing that. We ought not to own these patients who happen to be unrepresented, can't talk to us, and we want to protect them in the way that we think is protecting, which is a kind of paternalism, maternalism, right? That's what it is. We could call it parentalism. So can the discovery and potential for repair of lost or fractured relationships counter a legacy of violent separations? Or simply end the uncertainty and take the mystery out of missing forever? We've had patients we cared for where we did the search on the internet, so on and so forth, and families were unbelievably grateful that we found them because they hadn't seen their patient, could be 12 years. I remember her daughter said, I've been looking for him for 12 years. Psychiatrically ill person ended up in our hospital. This work is profound, and in my brain, it's like, I feel like it's like this parallel process. It makes up a little bit for the violence in some of the separations. Okay. You can tell. Makes me very sad. Okay. Maximizing our space and place. Beyond our, and through our psychosocial work, other voices are raised as we act as clinicians, leaders, colleagues, and at times clowns. This was really interesting. I read, I only get the Sunday Times and I have trouble getting through that, but I always read the magazine section, and they were describing this person whose name is Jonathan Majors, who's an actor, and they were describing him. And they talked about a clown, and I really had no idea that clowns in the classical sense is an interloper who listens to the world with unabashed curiosity and then disrupts. The game changer who speaks truth to power, the best and worst of our nature and does this without fear. So, on that note, this is the end of this conversation. I'm going to say be a clown. You should get a button that says I'm a clown. Go back to your settings and I'm a clown. I just love the ideas implicit in this. Who listens to the world with unabashed curiosity. So that's the discovery part, right? What's happening here? What is this family bringing? And so on and so forth. And then disrupts, speaks truth to flower, the best and worst of our nature. And the other thing about this, because you are psychosocial folks, is how you disrupt is a clinical decision. You need to think about how to maximize your impact and how not to be. Every once in a while, I would be rude. I'll call it rude. I can't think of another word right now. But most of the time, the work is really trying to figure out, how am I going to say what I need to say right now? How am I going to support? Because patients count on their doctors, families count on their doctors in many different ways than they count on us. Doctors have enormous power. They truly do. They may not always feel empowered, doctor in the audience, but they really do have enormous power. And we have to be really, really careful to understand the importance of those relationships, just the way you would do in a family, with a family. What are the relationships here? What alliances do we absolutely have to support? How do we speak up? How do we help this physician? I remember I was working with a physician in the intensive care unit, and African-American family, Asian doctor, and me. And the doc was so intent on trying to get this family to say that they didn't want the patient to be resuscitated if something happened and the heart started to stop and so on and so forth. And I could watch this family go from sitting there like this. After we were finished, they were like this. She saw none of that. And I could not help her. It didn't matter whatever I did, because the truth of the matter is that she never respected me anyway. So how could I have helped her? Used, but did not respect. And so that was very, very interesting. But we noticed those things differently. That's the lens that you bring. That's the lens that you bring, and it's tremendously valuable. The question is, how do you say something respectfully to get the change that you want, and to protect people from doing harm when they don't even know that they're doing harm? They don't know it. There's something disrespectful about letting others do things that are harmful, and we don't let them know in whatever way we find to try to influence that. And sometimes when you try to influence, what you learn is that their lens is different than your lens and what they were seeing. And so you end up knowing that you weren't so right in the first place. So I thank you very much for your attention, and actually for the opportunity to pull this together, because it forced me to just think about so many different aspects of the privileged work, truly, that we are privileged to do when you enter the lives of patients and families in this way. Thank you.
We have about 5-10 minutes for questions. I know there's some questions from the audience. With the lights, it's pretty hard to see you guys, but if you want to raise your hand and shout your question out loud so the mic could pick it up, the floor is yours. If not, we have tons of questions we'd like to ask, but probably it's another conversation we will have in the future. There are too many questions. From the audience, any questions or comments, reactions?
I don't know if this mic is working or not. It is. So, I mean, my question is just thinking about on a specialty palliative care team, like, how do we best differentiate and recognize the skills of the social worker in sort of a consultative model? Because I feel like there's all these overlaps with multiple members of the palliative care team coming to family meetings. There's some level of redundancy. There's a team-based social worker and the palliative care-based social worker, and just trying to think about, and I get what you're saying, but the language, but using that person's skills to the best utility and helping them feel fully valued. I'm curious how you practically make that work.
Yeah, I think part of the answer to that question also has to do with the setting that you're working in, and the workflow. Sometimes the workflow determines who goes where. I mean, Phil Higgins would say that he used to do some initial outreach for the palliative care consult service because the doctors needed to be in different places. They needed to be managing pain somewhere, and we couldn't do that. But we might be able to assess, you know, somebody's referring for goals of care. We might be able to make an initial contact there and understand that in a way that helps the doc who's doing the pain and symptom management and also billing. You know, you can't get away from the finance of all this. At least in the States you can. In Canada, I think, is different because you have some semblance of universal health care. Well, we do not, so billing is very, very important. I think also that all palliative care specialty social workers do not have the same skills. Some are learning, so they are different than folks who have been in practice for 10 years or 20 years or whatever it is. And so I think that's part of it. What do they need to learn? You know, when do you want to bring them with you because they haven't had this experience of going to the ICU? So part of it, in my brain, is also as a team, what kind of exposure do you want for certain social workers who are entering your team or been in your team for a while, but not had certain experiences that you would like them to grow in? The other thing that I think about with this is the consultation with the unit social worker. We need to build up that part of our work. That's the fluidity that I'm talking about. It isn't necessarily true that two social workers need to be in a room. And sometimes what I needed to be doing but didn't was reach out to the unit social worker, tell me about let's talk about this family. We've gotten a referral. How are you involved with this family? Tell me what you think is going on, so on and so forth. By doing that, you validate that role. You validate that role. And the palliative care social worker makes an autonomous decision. I don't think I need to be there for this family meeting. It's not somebody telling them where they need to be. I don't think I need to be there for this family meeting. I talked to the unit social worker, and this is what he or she said. Da-da, da-da, da-da. And so then the people who actually are going to the family meeting are armed, informed, and the social worker says, listen, you do this family meeting, unit social worker. You'll love my team. They're really great, and they'll love you. You do the family meeting, and then we'll talk afterwards. So I think there's not always, for me, sort of one answer. It depends in part on the situation that you're being asked to engage in. I do think, though, that I believe that we listen differently. I mean, I know that we listen differently, and I know also that in some teams there's competition for the psychosocial work. People love it because you get to sit down, you get to engage with another human being. The other part of it, I would say, is that what do people need to learn? So if you're in an academic teaching situation and you've got medicine fellows coming in, you may very well want the palliative care specialty social worker to go with the fellow because they have a different knowledge. They will teach something different to this fellow by virtue of their responsiveness, and so on and so forth. So it's sort of situation dependent. But I think it's an opportunity to affirm and validate the other social workers and their work in the institutions where we work, and also to create opportunities for shared learning. So somebody says to the social worker, you need to do this family meeting because you haven't been in the ICU or you haven't done any work with transplant patients. So this is an opportunity for you to learn, to hear the transplant docs, how they think about things, and so on and so forth. So other thoughts about that, because you are also working on teams. How do you think about it?
I think, like you mentioned, the privilege of being able to hear the voice of the patient, the family, the systems, the community, and maybe at large, the society also. And we have, I think, a great responsibility to be that voice of patients that are going through treatments and through care plans that are not able to voice their message. Mm-hmm. I think we have a great burden, but also a privilege of raising that voice, either through teaching, through discharge planning, through research, because very often in research and palliative care, we get the voice of healthcare workers, sometimes caregivers, but where's the voice of the patient? Even
Yeah.
research, I think it's lacking.
Yeah, and I think also what our doctor is talking about is the actual pressures of doing this work on a day-to-day basis and who goes where, and how do you decide who goes where, and part of it is as you say, there are certain situations where you want somebody listening who comes with a different skill set, comes with a sense of community and a sense of, and there are other places where, for example, the initial consult or the initial conversation may be very much about pain and symptom management, and there's not going to be a lot of conversation about other stuff until you get their symptoms managed, because they can hardly talk. They're in pain or they're short of breath. So unless you have a social worker, and I'm a nutcase because social work is so underrepresented in pain and symptom management. But if you have a social worker who understands that they can come with you when you have to manage somebody who's short of breath, and they can stand by that bedside and say to some patient while the doctor gets the medicine, examines you, listen to my voice, breathe with me, so on and so forth, so you calm that person down. Sometimes I've done listen to the sound of the oxygen, because you want to get people out of their body. Right? Not thinking about, I'm dying, I can't breathe. You want to get them out of their body. So if you have a social worker on your team who has some skills around pain and symptom management, you'll often say to that social worker people did to me, come with me. Come with me because I need you to be doing this while I'm doing this, and so on and so forth. And you treat it, I used to work with docs who said unmanaged symptoms is a medical emergency. It's an emergency. We treat it like it's an emergency. So I think all those things, I'm not sure if that's terribly helpful, but I think all those things sort of can be in your list of considerations. And it's also an interesting conversation to have with all the members of the team. I've been thinking about this. I'm trying to figure it out. I want to do the best for patients and families, and also for your learning, and for how we work together. Sometimes we have to make hard choices. Yep. I will feel very gratified if I would feel so good at the end of my career, whenever that's going to be, if more social workers felt pain and symptom management to be part of their responsibility. It's such a rich area for us to enter. I can send you some articles about that too if you want to email me.
In conclusion,
Yeah.
can we have a few words on your work on deaf in America and our views as social workers as a good deaf, and how it could unfold in so many different realities, as you so eloquently said during your presentation. There's so many ways of dying, but yet palliative care sometimes portrays the good deaf paradigm.
Yeah. So the project on death in America, my participation in that really was to create a fellowship, a social work fellowship, postgraduate fellowship, and then we created the listserv. I always get nervous about the phrase "the good death," because I think we have ideas about what that death should look like. And once you have experience, and then I think to myself, and you will work with these folks, somebody who's 32 years old, leaving 2 young children, we're talking about them letting go and a peaceful death. How do you die at 32 when you're leaving your family and leaving kids, and not struggle, and not want somebody to attempt to restart your heart? And so that's the context. That's what makes me nervous sometimes about this work that we do, and then we feel like failures because we didn't achieve this idealized version of what a good death looks like. And so I think becoming able to sit with and to learn from folks who choose another path is really, it's a gift. It's really a gift on so many other levels. And it takes a while, and if you really work in systems, and hospice it's kind of, talks much more about this, I think, than palliative care does, what a good death looks like, and there's the whole rituals, at least in the States, and the rules about hospice really make it sometimes difficult to accept the variation in how people see living and dying, not just dying, but living, how they live their lives. Yet it is a gift if you continue in this work. If you continue in this work. I remember, I'll just say this shortly because my time is up. I remember this 30-something-year-old man. The only way I got to see him was the head nurse on the floor trusted me. And so she, you know how like you go in on somebody else's coattails or something? She said, I want you to meet this family. I want you to meet this family. So she introduced me, and I was the only one who didn't speak Spanish. Every family meeting, she would sit next to me and interpret what was going on in the family meeting because and everybody else spoke Spanish. And this person, a young man, he was in his 30s, he'd been in prison, had lots of tattoos. It was like he was going to fight for his life. And he went home with hospice on patient-controlled analgesia. And he was coming to the end of his life, and he knew something was changing in him. And he looked at his mother, even though he was, quote-unquote, not to be resuscitated. He looked at his mother, and he said, call 911. And she called 911. He looked at his mother and his kids, called 911. And he died being resuscitated, and an attempt to resuscitate in the ambulance. And we went to his funeral in his wake. They had T-shirts with his picture on it, and the representation of him as a fighter. That was his legacy. So he died. You know, so I can think about it like cross-country skiing. Some people cross-country ski. Some people do extreme skiing. They do extreme. Those people are not going to come to the end of their lives in the same way. Maybe they will, maybe they won't. But they live their lives differently. Yes.
You stimulated a lot of thinking because in Quebec, in order to be admitted into a palliative care unit or hospice, not palliative services is different because that's for the outpatient population, but you cannot come into a palliative care unit or a hospice unless you've agreed to not be resuscitated. So is that different in the States? No. Okay.
No, yes, it absolutely is different.
Okay.
Our palliative care unit, you could, I'm sorry. Our palliative care unit, you could expect and anticipate a resuscitation. The challenge with that is also, though, you have to help those patients to understand. Palliative care unit and hospice units, those nurses are not, that's not what they're trained to do. You know, they'll do it, a team will come in, but if you want immediate, you know, somebody who's going to respond like that, so you have to prepare those folks for the fact, yes, we can try and do this for you. But you really need to know that's not what these nurses do for a living, right? On their day-to-day basis, it's like, you know, there's ICU nurses, there's hospice nurses, there's ED nurses. They think and look at things differently. Their skill set's a little bit different. So yes, we did, but we also had to prepare them for the fact that it's different here. The focus is different.
So it just makes me think that we're missing a lot of people who could probably really benefit from palliative care, but just are not ready to accept
Yes,
that.
and you could be doing that work in the setting of good pain and symptom management, so on and so forth. Yeah, exactly.
Thank you.
Yeah, you're welcome. Okay, I'm gonna get,
I hate to break this up. I feel so bad, but I know that Terry has to leave, and I really want to thank her so much for taking the time to come all the way here to speak with us. So much food for thought, and so we'll carry that throughout our day. It's break time now, so I'll let you all have and go get a coffee and come back at 10:30 to join us, and we have another great speaker that will take us right into lunch. So thank you so much, Terry, for taking the time to come out.